This is Chapter 43, Hematologic and Immunologic Dysfunction. Okay, so several tests can be performed to assess the hematological function. One of the main tests that we do is a complete blood cell count. You guys are all used to using this. It's not very much different than in peds than it is the adult world. However, because it's pediatrics, there are some different parameters in certain testing. If you look at page 1363, it will show you the tests that are performed under the complete blood count for children. Another way of identifying this type of dysfunction is to look at the history and physical. What are some of the things that we look for in the history and physical? Well, the parent may say the child just doesn't have a lot of energy, is tired all the time. I think we need to put this in perspective. A lot of times I'll have an adolescent come into the office and the parent will say, oh, that she's tired all the time. She complains when she has to do her chores. She's sleeping all the time. She won't go out with her friends. And then you kind of have to ask questions. Well, my first question is usually to the adolescent herself or himself. Well, what time do you go to bed? Oh, well, I go to bed at 11. Okay, but what time do you go to sleep? You go to bed at 11, but you're up playing video games, you're talking on the phone, so maybe you don't fall asleep until 2, and then you got to get up in the morning to go to school, and that's when the parents are complaining, I just can't wake them up in the morning, they're so tired. So anyway, looking at this, you kind of have to delve into the fatigue a little bit with your history. But parents will complain, or the child will complain that they just don't have enough energy. Sometimes the parent will complain that the child eats fast food all the time, that they're concerned that they're not getting enough of the vitamins and minerals that they need. So a lot of this can come out in the history itself. And then the physical, you would look at any easily bruising, maybe being very pale, and a good test for, or what you look for in a child with anemia, you look at the palm of their hand, and it's very, very white, and the blanching, there's hardly any blanching that goes on. So those are the kinds of things that you can look at in the physical exam. Frequent infections, if their immune system is down and they're just getting ear infections all the time, upper respiratory infections all the time, that's another clue as well. So we're going to talk about red blood cell disorders, and one of the first ones is anemia, and that's the most common blood disorder of childhood. And basically, it's a decrease in the number of red blood cells. It's decreased oxygen carrying capacity of the blood. If there's a decrease in the amount of oxygen available to the cell, I'm sorry, let me go over the slide one more time. So anemia is the most common hematologic disorder of childhood. There's a decrease in the number of the red blood cells, or hemoglobin concentration is below normal. If there's a decrease in number of red blood cells, we know that these red blood cells carry oxygen to the cells. If there's not enough of them, then there's not enough oxygen getting to the cells. And then, of course, the causes are depletion of red blood cells or hemoglobin, or both. And we look at all the morphologies, all the different characteristic changes, size, shape, color, and any combination of these. The diagnostic evaluation is sometimes defined as a hemoglobin below 10. I really think it depends on the lab, and I really think it depends on the age of the child. So you really have to look at these things a little bit more close. So anemia can occur in many different situations, and if you look on page 1364, there's a good breakdown of all the different kinds of anemia. So if you look at decreased red blood cell production, under that is iron deficiency anemia, and usually nutritional in nature. bone marrow failure, aplastic anemia, malignancy, leukemias, and we'll talk about those in a little bit. Then the increased red blood cell loss, and these are the symptoms that you see: pallor, fatigue, headache, very much similar across the board in all the anemias. But this is usually from acute blood loss, like nosebleed, hemophilia, ITP, DIC, and we'll talk about those as we go as well. And then there's increased red blood cell destruction. And that's usually like sickle cell disease, thalassemia, and then it can be immunologic as well. That's a good breakdown of the classifications of anemia. So the effects of anemia on the circulatory system, of course, there's hemodilution, decreased peripheral resistance. Therefore, you have increased cardiac circulation, turbulence. They may produce a murmur, and this might be one of the first things that you hear in a child with anemia. If the anemia has not been diagnosed, and you listen to a child, as part of your physical assessment, and you hear a murmur, it might be something that you might want to check into. Ask the doctor to do a CBC. Tell the doctor, I hear a murmur, and this child has never had a murmur before, perhaps we should look at anemia. But that's very common. Cyanosis and growth retardation is other effects as well. So the therapeutic management of anemia is obviously we need to find the underlying cause. Is it one of these three? Is it decreased red blood cell production, increased red blood cell loss, or increased red blood cell destruction? Sometimes transfusion, if a hemorrhage has occurred, nutritional intervention for deficiency anemias. Sometimes all we need to do is replace the IV fluids and get the fluids replacement up, oxygen therapy, and bed rest. The care depends on the age of the child. We want to get a careful history. Again, the assessment, that's so important. The history and physical is so important to determine what type of anemia may be taking place. Of course, we're going to have to get lab tests, so you want to prepare the child. You want to educate the family on the different types of lab tests, blood tests, what you're looking for, and then when you get the results, of course, you're going to, that will be part of it as well once the doctor gives them the results. And where he's going with this is the education. Iron deficiency anemia is caused by inadequate supply of dietary iron. So what we need to say about this is, when a baby is born, he gets his iron from his mom, and usually for the first 6 months. And especially if they're breastfeeding, they will get the iron from the mom. If they're not breastfeeding, then they will have iron fortified formulas, supplemental formulas. If they are breastfed, they don't need that iron for the first, or they're getting iron fortified formulas. They don't need any iron from outside, from any other additional iron. And it's not until they reach 6 months that they're going to need that. So and basically that's when we start the solid foods, is at 6 months. We don't, as in GI, as I've said before, we don't recommend starting solid foods until 6 months because they need that formula. They need an iron fortified formula. And formula is all they need for vitamins and minerals. Once you start introducing the solid foods, then they're going to cut down on their formula. So it's not needed to 6 months. Sometimes pediatricians will start it between 4 and 6 months, and that's okay. They just don't need it until 6 months. And then at 6 months, all those cereals, the rice cereal, the oatmeal cereal, it's all iron fortified. So therefore, they start to get their exogenous iron. Special needs for premature infants, and usually they're either on breast milk or breast milk fortified with nearshore formula or some type of formula that will have iron in it. And then adolescents are at risk, usually because they have such rapid growth during that time, and they also have very poor eating habits. So nutritionally, they're very poor, and so they will need, then they become at risk for iron deficiency anemia. And so the pathophysiology is caused by a lot of different factors. One thing that I do want you to be aware of is something that we call milk babies. And milk babies are just that, just what I talked about. If they get too much milk, well, just what we've been talking about, they don't really need that iron until they are 6 months of age. But at 6 months of age, then they start needing, once we start introducing the solid foods, and we see these milk babies not usually in infancy so much as we see them in toddlerhood, because then they start drinking so much milk. They have so much milk. And I mean, I've seen, parents tell me that they drink 30, 40, 50 ounces of milk a day. Well, if you're drinking all that, milk is a very poor source of iron. So if they're drinking all that, then they're not getting their iron-rich foods. So that's what we call them milk babies, and we see milk anemia. So that's something to watch out for it as well. So when you get a toddler, 1-year-old, 2-year-old, the nutrition history is very important. The parents will say, oh, they're such a picky eater. They'll only eat, a couple bites of chicken. They won't even touch red meat, blah, 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 and they won't eat a whole lot. But boy, are they drinking their milk. And moms think that it's really good that they're drinking their milk, and it is. They just don't need 50 ounces of milk a day. And so you have to cut back on the milk. And sometimes in toddlerhood, it's very difficult to kind of manage or control their appetite, because number one, they are very picky eaters. And number two, the moms want them to eat. They want them to eat or drink. But if you cut back and you try and manage that, eventually they will eat and drink. And so sometimes if it's very difficult to do that, they may need exogenous iron. And of course, there are multivitamins with iron available if needed. Okay, so sickle cell anemia. Now this would come under the increased red blood cell destruction, and one of a group of diseases termed hemoglobinopathies. There's a partial or complete replacement of normal hemoglobin with abnormal hemoglobin S, and these are all the different sickle cell diseases. It's an autosomal recessive disorder. 9% of African Americans are carriers. They have the sickle cell trait. 40% of Native Africans are carriers. If both parents have the trait, each of their children has a 25% chance of having disease. So genetic counseling is very important. In areas of the world where malaria is common, individuals with sickle cell trait tend to have survival advantage over those without the trait. The clinical features: obstruction caused by sickled red blood cells, vascular inflammation, increased red blood cell destruction, abnormal adhesion, entanglement and meshing of rigid sickle-shaped cells, local hypoxia, and cellular death. And we'll talk a little bit more about this. So I actually want to go to the 2 slides down, and this slide is very good. It shows the normal red blood cells on the top picture, on picture A. You see how they just kind of flow through the vessel. That's normal hemoglobin, no problem. And then in picture B, you see the sickled cells, the sickled red blood cells, and how they call them sickle because they're actually shaped like a sickle, and how they can actually occlude the vessels and cause issues. And then if we go back to a slide, again, this kind of shows the same thing. In A, the nice red blood cells and how they kind of go through the vessel without any issue, and then in B you see some of them are sickled and how they can cause occlusion. And if they occlude a certain vessel that goes through these organs, that's when the organs are affected. So a lot of the organs, we have the blood supply, the blood or the vessels that are supplying the lower extremities. Sometimes you'll see swelling. The upper extremities you'll see swelling. Can affect the heart as well. I mean, if it affects the brain, we might see stroke or paralysis or even death. We have, there are children that do have strokes because of the sickle cells. Obviously, it can include the spleen. We have splenomegaly, hepatomegaly, causing a lot of pain. Priapism is another one, occluding the vessels that supply blood to the genital area, and in males we see the priapism, or the actual constant erection of the penis, and it's very painful. This is seen a lot, but along with the sickle cell is a lot of the pain. The prognosis for sickle cell: there is no cure except possibly bone marrow transplantation. So we need to be, as part nurses, very supportive care, prevention of sickling episodes. That's where our education comes in, and we'll talk about that in a little bit. They get frequent bacterial infections because they are immunocompromised. They can get sick very easily, and this sickness can also cause a sickling or cause a crisis. Bacterial infection is a leading cause of death in young children with sickle cell disease, and their usual lifespan is now into the 5th decade. So that's good. That's very good. So sickle cell crisis, there are precipitating factors. Anything that increases the body's need for oxygen or alters transport of oxygen. Now remember, these red blood cells carry oxygen into the cells. If we don't have them, then the cells aren't getting their oxygen. Trauma, infection, fever, any kind of stress, physical stress or emotional stress, hypoxia, lack of oxygen can certainly cause the crisis as well. And so the treatment of the sickle cell is medical emergencies, sickle cell crisis, rest, minimize energy loss, hydration through oral or IV therapy, drinking, and this is prevention as well. I mean, we want the kids to drink a lot. Hydration is good for kids with sickle cell disease. Electrolyte replacement, analgesia for pain. Pain control is very important. Blood replacement for anemia if needed, and antibiotics for infection. Sometimes these children are put on prophylactic antibiotics for 2 months to 5 years, secondary to ongoing infections, to prevent infections. Monitoring of reticulocyte count regularly to evaluate bone marrow function, and then blood transfusions, if given early enough in a crisis, may reduce the ischemia. Because why? You're getting the good red blood cells into the body. Education. As far as our role, as a registered nurse's role, education is huge in this instance. Genetic counseling is huge as well. But we can educate the family and the child. And of course, this is a huge specialty, even within hematology, even within the specialty of hematology. Seek early intervention for fever. If the child is school age, the school nurse needs to be alerted to this. The teacher needs to be alerted to this. The child needs to drink. We need to have constant hydration. And certainly if they're not feeling well, they need to be allowed to go down. They need to be allowed, we need to take the temperature, record the fever, treat the fever. And then recognize signs and symptoms of splenic sequestration. Provide supportive therapies during crisis and meet psychosocial needs of the family. Thalassemia. Thalassemia comes under increased red blood cell destruction as well. This is a common genetic disorder. It affects mainly descendants of people living near the Mediterranean Sea. Normal postnatal hemoglobin includes two alpha chains and 2 beta chains. Anemia results from defective synthesis of hemoglobin, structural impairment of red blood cells, and shortened life of red blood cells. There's an overabundance of erythrocytes is found in the bone marrow. There's 4 types of beta thalassemia. I don't want you to get too over involved in this. One that probably stands out the most is Cooley's anemia or thalassemia major, and that's severe anemia necessitating transfusions to survive. Sometimes the onset may be insidious. Sometimes it occurs, we may say the latter half of infancy. If the family has a history of living in the Mediterranean, Italians, Greece, in that kind of area, the risk goes up. Getting the history is huge. Low hemoglobin hematocrit values, red blood cell changes often seen by 6 weeks of age. The presentation is severe anemia and growth failure. Blood transfusions to maintain normal hemoglobin levels. Potential complication is hemosiderosis. However, that's iron overload. That's all that we can simply call it, iron overload. And of course, we can treat that with iron chelating drugs. The prognosis of thalassemia: expect to live well into adulthood with proper clinical management. The common causes of death are heart disease, post-splenectomy sepsis, multiple organ failure. Bone marrow transplantation is a potential cure. Promote compliance with transfusion and chelation therapy. Assist the child in coping with anxiety-provoking treatments. Foster the child's and family's adjustment to the chronic illness, and observe for complications of multiple blood transfusions, which would be iron overload. Okay, so aplastic anemia. This is pancytopenia. And what do I mean by that? That means the depression of all formed elements of the blood. Now this is, again, this is decreased red blood cell production. It depresses our red blood cells, or hypoplastic anemia. Okay, just to clarify, hypoplastic anemia is the depression of red blood cells but normal white blood cells. Pancytopenia is the depression of everything, of the red blood cells and the white blood cells. Okay, aplastic anemia causes are primary or congenital and secondary acquired. Diagnostic evaluation, again, is usually with the CBC, and it can be very slow going as far as diagnosis goes. Therapeutic management is immunosuppressive therapy or bone marrow transplantation. The nursing care is pretty much similar to everything that we're going to talk about, including leukemia, and we'll be talking about that in a little bit. So onto the hemostasis, the defects in hemostasis. Here we're talking about clotting. And there's three types of defects. Well, when we talk about clotting, it's the whole clotting mechanism, and we have to review, in order to, you should be reviewing the clotting mechanism for all. So we're going to be talking about the clotting mechanisms. For clotting, three things will take place. Release of clotting factors and platelets in response to injuries, formation of thrombin, or formation of fibrin, and one of those three has to take place in order to produce a clot. So now we have defects in the clotting factors, or defects in the hemostasis. Hemophilia is one of them. This is a group of hereditary bleeding disorders that results from deficiencies of specific clotting factors, and then we'll be talking about the different clotting factors. In 80% of the cases, the inheritable pattern is X-linked recessive. Identification of a specific factor deficiency allows for definitive treatment. So here you have, as an example, hemophilia A is a deficiency of factor 8. Hemophilia B is known as a Christmas disease, and that's just because of the way the clotting mechanism goes. Caused by deficiency of factor 9, and then the von Willebrand disease is deficiency of the von Willebrand factor or factor 8. Hemophilia A is a classic hemophilia. This is what we hear mostly about, and this is what we see. So the diagnosis of hemophilia, again, history, take the history. Is it in the family? Because it is genetic. History of bleeding episodes, overt prolonged bleeding. Hemarthrosis, bleeding into the joints, or ecchymosis, frequent bruising. It's an X-linked inheritance, and so you need to look into the family. Laboratory findings, we suspect it, then we can look at levels of factor 8, 9, PTT, PT normal. Findings of platelet count, you might have a normal platelet count, parathyroid hormone level, and fibrinogen level. So the management makes sense. It would be replace the missing clotting factors. Home infusions right on the spot can be done. DDAVP is IV administration or nasal spray, and this has been found to increase factor 8 activity. And then the aminocaproic acid prevents the clot destruction. Usually with mild to moderate hemophilia, patients live near to normal lives. Their main goals are controlling symptoms and limiting joint damage, which will improve their quality of life. Their treatment options, gene therapy, and that right now they're working on a copy of the factor VIII gene, which has been introduced. The care management of hemophilia, obviously we want to prevent the bleeding, we want to provide a safe environment for bleeding. Dental hygiene, why do you think that is? Because of the closeness of the mucous membranes and the brushing of our teeth, we can bleed. We want to recognize and control the bleeding. RICE is very good. Rest, ice, compression, and elevation. Is important in order to prevent the crippling effects of bleeding. You know, if it bleeds into the joints or there's some painful areas, of course they're not going to move those areas very much, and so passive range of motion to active range of motion exercises are very important to institute during this time. And then support the family and home care. Genetic counseling is huge. On to immune thrombocytopenia, ITP. You may have heard it be called this. ITP is also known as idiopathic thrombocytopenic purpura. It's an acquired hemorrhagic disorder characterized by, number one, thrombocytopenia, excessive destruction of platelets. Here we have a platelet issue. Purpura is a discolorization caused by petechiae beneath the skin, and then normal bone marrow with increased number of immature platelets or eosinophils. Has anybody ever seen anybody with ITP? They have a lot of petechiae all over their body. This is usually very acute and self-limiting. It usually follows some type of infection, usually an upper respiratory infection, and it can take up to 12 months or longer to actually completely go away. The management, we have to, the diagnostic evaluation is pretty much clinical. Therapeutic management, primarily supportive. Sometimes they can get IV immune globulin, an anti-D antibody, but the prognosis is self-limited course without major complications. Sometimes, by the way, sometimes they are put on oral prednisone, but most recently they've been placing them on anti-D antibody regimen. Okay, disseminated intravascular coagulation. Now we talked about this as being an increased red blood cell loss. And this is a disorder of coagulation that occurs as complications of other types of pathological processes like hypoxia, acidosis, shock, and endothelial damage. The first stage of the coagulation process is abnormally stimulated. Excessive amounts of thrombin are generated, and fibrinogen is converted rapidly to fibrin with aggregation and destruction of platelets. They just bleed out. The therapeutic management, what's really important is the early recognition, control of the underlying or initiating cause. They can do platelet transfusions. Usually there's a whole exchange transfusion in the newborn, and IV heparin. Epistaxis, nosebleed. These are isolated and transient. Epistaxis is common in childhood. Recurrent or severe episodes may indicate underlying disease, such as leukemia, thrombocytopenia, other clotting factor deficiencies. A lot of times it's just from upper airway issues, nasal issues, very dry air. Allergies can cause that too, can cause that as well. So control, it's very important. I mean, sometimes, especially if the mucous membranes, the nasal mucous membranes are very vascular, so if there's an allergy associated with it or whatever it's coming from, they can bleed a lot. And it's very scary, especially for the first time to see your nosebleed. And it's very scary any other times. Usually the kids get very upset. So it's important to remain calm. It's important to educate the parents and the child on what to do when they see that nosebleed. It usually stops within 10 minutes after pressure. So you just have the child sit up, lean forward. A lot of people think you want to lean the head back, but you don't want to lean the head back. You want to lean, because when you lean it back, all that blood drips into the stomach or the lungs. And so we want to make sure that you're leaning it forward so it's not so much drainage back into the stomach. You want to have them sit up, lean forward, apply pressure to the softer part of the nose, and evaluate further if bleeding continues. Now there's other, but there's other things that I've heard. You want to put ice pack on their forehead, ice pack on their neck. It's not going to hurt. It might help. It's not going to hurt. But basically you want them to lean forward and just pinch really hard over the bridge of their nose, and don't let go for 10 minutes. And once you let go, you don't want them blowing their nose. Once you let go and it's done bleeding, you formed a clot, and that's a good thing. And you do not want them to undo that clot. Now, if it doesn't stop bleeding, then it may, or if it continues to start up, if it starts up again and you have a hard time stopping it, then I would call the pediatrician. Tell them to call the pediatrician. Maybe go to the ER. They might need it cauterized. Neoplastic disorders. This is the leading cause of death from disease in children past infancy. Almost half of all childhood cancers involve blood or blood-forming organs. Leukemia and lymphomas are the ones that are the most prevalent. So leukemia is the most common form of childhood cancer. There's 3 to 4 cases per 100,000 white children under the age of 15. That's a lot. More frequent in boys over 1 year old. The peak onset between 2 and 5 years of age, and there is survivability. Now there are several different types of leukemia. It's very broad disease of bone marrow and lymphatic systems. The morphology of leukemia, these are the basic ones: acute lymphoid leukemia, ALL, acute non-lymphoid leukemia, ANLL or AML, and then stem cell or blast cell leukemia. So basically, leukemia is an unrestricted proliferation of immature white blood cells in the blood-forming tissues of the body. The liver and spleen are the most severely affected organs, and leukemia demonstrates the same neoplastic properties as solid tumors. Although leukemia is an overproduction of white blood cells, it often, an acute form, causes low leukocyte count. Cellular destruction takes place by infiltration and subsequent competition for metabolic elements. In other words, the white blood cells, or the overproduction, takes over and infiltrates the good stuff, the good cells. The consequences: you get anemia from decreased red blood cells because the white blood cells take over. There's an infection from neutropenia, bleeding tendencies from decreased platelet production, and marked infiltration, enlargement, engorgement, fibrosis of the spleen, liver, and lymph glands. So the diagnostic evaluation of leukemia, it's based on the history and physical manifestations, fever, sickness, lots of different types of sickness, low immune system. Diagnostic would be low blood counts, neutropenia. Physical, we would see, on a physical exam, we would see lymph node enlargements. We would feel an enlarged liver or spleen. A lot of times this is caught on blood prior to the liver and spleen becoming very enlarged, but it can happen. They will do a lumbar puncture to evaluate the central nervous system involvement, as well as a bone marrow aspiration or biopsy. The therapeutic management of leukemia, there are 4 phases of therapy. I don't want to get too involved in this. It's pretty, these 4 phases are pretty much the same for everything. For all the different types of leukemia. Once you diagnose the certain leukemia, then you can really get very complex, depending on what their treatment is. And each leukemia has their own little protocol treatment depending on what kind. But basically there's 4 phases. There's induction therapy, which usually takes 4 to 6 weeks. Then there's central nervous prophylactic therapy. This is usually intrathecal chemotherapy. Then there's consolidation therapy to eradicate all the leukemic cells and prevent resistant leukemic clones. And then there's maintenance therapy to preserve remission. Of course, stem cell transplant for leukemia, the donors may be relatives or non-relatives. Then they match them. They look at the antigen matches or mismatches. Peripheral stem cells may be used. Umbilical cord blood. Graft versus host disease is huge and has to always be looked for. This is when newly transplanted donor cells attack the recipient. cells. And so, in other words, rejection, and you get disease actually. I know from the GI standpoint, a lot of times, after um, after the transplantation, we always watch for graft versus host in the GI tract. And if they're having a lot of, this is usually a couple months afterwards it can occur. And so, after a couple months after transplantation, and so if in the GI system, we'll see if we see bloody stools, diarrhea, and we can't figure out any other reason why they're going in to do a colonoscopy, abdominal pain, or maybe some coughing up blood, those kind of things, or vomiting blood. Um, then we'll go in with folks to see if there's any disease process going on. The prognosis factors for determining prognosis is usually dependent upon the initial white blood cell count, the age at the time of diagnosis. There's a certain age, and I believe your book goes over those ages, but I think it's between 3 and 12. If it's diagnosed in that time, it's usually a better prognosis. The type of cells involved, the gender, the karyotype, all those involved in the prognosis of the leukemia. Care management, again, I'm going to say this with, with admiration, are the nurses who work in oncology, whether it's pediatrics or adults. It's huge, and I highly respect them because it's a diagnosis that obviously no family wants to hear, no child wants to hear, and the nurse is the one that is there for support. The child goes through a lot of procedures, lumbar punctures, blood draws, and then the chemotherapy if he needs it. And so the family has to be educated on everything. Again, I will say that all children, because I have worked with the nurses and the doctors on the hematology floor, hematology oncology floor, 7 South. And they are on top of it. I mean, they know those parents. The parents know them. The parents trust them, obviously, and they well educate both the family and the child. Of course, another part of the management is to prevent complications, infection, hemorrhage, anemia. And you notice that when you go on to 7 South with the doors, you go in one set of doors, you wash up, and you can't go onto the floor, through the next set of doors and onto the floor until those previous doors close, and the same is coming out. So that's one way that they, among other ways, but that's a very interesting way that they can do to that's another interesting way that they can do to control infection. Okay, I'm sorry, let's go back here a little bit. Okay. We are going to pause this. Okay, I apologize. I was having some technical difficulties with my computer battery. Anyway, we're back online. We're back on schedule. So, so pretty much prevent complication of any myelosuppression, and that includes the infection, hemorrhage, and anemia, as well as the graft versus host disease also. When I don't think we talked about relieving the pain. Most pain that the children feel is the bone pain. And there is a lot of pain management that goes along with that, and we had talked about that in a previous chapter. But for leukemia, it can be bone pain, and we need to figure out how to relieve their pain. A lot of the pain is relieved by analgesia, but we have to, there may be different types of medications as well as non-medications that are used. So to continue on the care management of leukemia, of course there's a lot of problems associated with the chemotherapy drugs, nausea, vomiting, anorexia, a lot of ulcers, a lot of mouth problems. And one of the things that we see a lot is we call it leukemic mouthwash, and there's different recipes for that, but that's used quite frequently. Neuropathy, alopecia, mood changes, and you know, any of these symptoms are can be very devastating to any age child and to the parent. However, when there's change in physical attributes like alopecia, moon phases that we had talked about in the Cushing's disease, you know, then for adolescents this is huge as well, especially if they have friends and family coming to visit. Lymphomas are the third most common group of malignancies in children, and there's two types of lymphoma, Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma, not going to spend too much time on this, but just going to go over this in general. Neoplastic disease originating in the lymph system primarily involves lymph nodes that can metastasize to the spleen, liver, bone marrow, lungs, and other tissues. This is kind of a picture of the Hodgkin lymphoma child and the organs that it can involve as well. There's four types: lymphocytic, nodular, mixed, lymphocytic depletion, and the accurate staging is basis for treatment and prognosis. So there's something called the Ann Arbor staging, classification A and classification B, and this is usually based on the number of sites and the presence of the extranodal disease along with the symptoms. The diagnostic evaluation, clinical manifestations of Hodgkin's disease are lymphadenopathy, supraclavicular lymphadenopathy. It's huge. If you feel any nodes when you're doing your physical along or any swelling along the supraclavicular area, this is kind of a red flag for lymphoma. And some more symptoms are cough, abdominal discomfort, anorexia. Usually they'll do a node biopsy for diagnosis, and the presence of Reed-Sternberg cells are characteristics of Hodgkin's disease. So the therapeutic management is radiation, chemotherapy, and the long-term survival is excellent. And care management is just like for any of the other things that we've talked about, is preparation for diagnostic procedures, education on the disease, education on the treatment of the disease, side effects, and of course offer the family support. Non-Hodgkin lymphoma occurs more frequently in children than Hodgkin lymphoma. Clinical appearance is the disease usually is more diffuse rather than just in the lymph nodes. Cell type is undifferentiated or poorly differentiated. Dissemination occurs early, often, and rapidly. And mediastinal involvement and invasion of meninges occur. Then there is and also the prognosis for non-Hodgkin's is very good as well. So on to the immunological disorders or immunologic deficiency disorders. So the big one is HIV. And I think we all kind of know epidemiology behind HIV. The first Peds cases were children who received blood transfusions as well as maternal to child transmission in HIV-infected moms. Over the years, or now, we still see mother to child, although that's much more declined because of the counseling that's available for moms or for females, and as well as the treatment with HAART, or highly active antiretroviral therapy. This can be given before pregnancy or before birth, and it can help decrease the child. It's huge in decreasing the child getting HIV or becoming HIV positive. Now basically what we're seeing, we still do see some mother to child, and we don't really see the blood transfusion issues anymore. However, we do see, what we see on the rise is the adolescent risky behavior. Adolescents contracting it through unprotected sex and IV drug use. Just one thing I want to say about immunization is that it is very important that they get immunized because they have a low immune system, so it's very important that they get immunized. The live vaccines such as varicella and measles, they need to get those vaccines, but we need to kind of give them those vaccines when they are healthy, not when their immune system is down, but when they are healthy, or when their viral load is up, I guess I should say. SCID, or SCID, severe combined immunodeficiency, is a defect characterized by the absence of both humoral and cell-mediated immunity. And we see this in history of recurrent severe infections in infancy. They will be tested for it. Wiskott-Aldrich syndrome. This is a genetic syndrome. Very briefly, it's X-linked. It is characterized by thrombocytopenia, eczema, and immunodeficiency of selective functions of B lymphocytes and T lymphocytes. Management of hematological disorders we had talked about previously. Blood transfusions obviously is one of the management. We need to, and you all, most of you I think have given, well, I don't think you're part of giving blood in the hospital. You can't participate, but you can watch. And of course we have to verify the identity of the recipient and donor's blood group, monitor vital signs, use appropriate filter. The blood has to be in within 30 minutes, or has to be going within 30 minutes of its arrival. And then you infuse over 4 hours and monitor for transfusion reaction. If you haven't done this or haven't been part of it, or at least watching it, you need to do that. So in your, hopefully in the next year or next few months that you're in clinical, I would try and get to be involved in that in some way, shape, or form. The transfusion reaction to hemolytic is the most severe, but it is the most rare. Usually we see fevers and chills, allergic reactions, urticaria, pruritus, laryngeal edema, and air emboli can occur as well. And then there's the bone marrow cell transplants are used to establish healthy cells in both malignant and non-malignant disease. Ablative therapy is a high-dose combination chemotherapy to eradicate unhealthy cells and suppress immune system to prevent rejection of transplanted marrow. Stem cells are harvested from the bone marrow, peripheral blood, or umbilical vein of placenta. The stem cells are given to the patient by IV transfusion, and then newly transfused stem cells repopulate ablated bone marrow. Types, again, don't get too caught up in all this, but allogenic stem cells from the histocompatible donor, transplantation of stem cells from umbilical cord, and autologous, or cells from yourself, and then peripheral stem cell transplantation. Apheresis is removal of blood from an individual, separation of the blood into its components, care management. You can do that for yourself. And then question, when both parents have sickle cell trait, what is the chance that each of their children will have sickle cell anemia? And you guys can answer that. I know you know the answer to that. So this has been chapters 43, and 43 is the hematological chapter, and 46 is the endocrine chapter. If you have any questions on these recorded chapters, you can email me. My email is capital B, capital G, ursky@cci.edu. This class should have been held on June 9th, and I will be back on June 16th. The next class will be June 16th. However, I will be answering my email, so please do not hesitate to email me. I hope you guys have a very good next couple of weeks.